Welcome back to the Cut to the Chase podcast. I'm Nick Pappas. I'm a board-certified orthopedic surgeon in New Orleans, Louisiana. If you've watched the previous episodes, you know how this works. We typically cover 3 topics. I spend about 2 minutes each on each one, so let's get to it. All right, first topic, corticosteroid or cortisone injections. And are they just temporary? So I get asked this a lot, and I administer these a lot in the office, so I do end up talking quite a bit about it. What exactly does a corticosteroid injection do? Well, it's basically like a glorified anti-inflammatory that is more potent than something you could take by mouth because it doesn't get processed by your liver and your stomach. It just goes straight to the source. And it does do a good job at decreasing inflammation. Now, if you've got a problem that's a chronic problem like arthritis, or osteoarthritis, specifically where the ends of the bone, where the cartilage lies are worn, it's not going to fix that problem. But it will decrease the swelling and the inflammation, which is what causes a lot of the pain, and can dramatically reduce your symptoms. However, if you have a problem that's just a temporary inflammation problem, like a tendonitis that happens in, for example, tennis elbow or lateral epicondylitis, if the inflammation is really the cause of your symptoms, giving a corticosteroid injection can decrease that inflammation and can make your symptoms go away. So it depends on the underlying nature, but a corticosteroid or cortisone injection, by the way, we don't really inject cortisone anymore. We use different corticosteroids. For example, I use Depomedrol, and they can be quite effective, though, at making certain problems just disappear. So don't think of them as always temporary unless you have a chronic problem like underlying arthritis, but they can be very effective and can sometimes help prevent you needing surgery for a certain issue. Next time. All right, second topic, arthritis in general. How do I manage it? So the most common type of arthritis I see is what is known as osteoarthritis, which is when the cartilage at the end of the bones is worn away. And there are other types like rheumatoid arthritis, which is autoimmune, or gout. Those are managed a little bit differently, but the same principles apply. You're still trying to just decrease the inflammation. But osteoarthritis is the most common one I see, and I'm starting to see it in younger and younger patients. It used to be around 50 where I would see it, but I'm even seeing it in patients in their 40s. So what's the deal with arthritis? Well, about half the time osteoarthritis has some genetic component to it. So something to be looking out for in all of us, to be honest. But once you start getting symptoms, how do we manage it? Well, the first thing we try to do is figure out if there's some activity that's really irritating it. Obviously try to avoid that. Most people, in terms of medications, will try to do something like Tylenol at first or an ibuprofen. You can get issues with NSAIDs or Tylenol due to side effects. So some people favor a topical. Probably the most popular topical overall is Voltaren gel or diclofenac. Now, if you have issues with that, an alternative to that I've seen good results with is a topical CBD, which works a little differently and has fewer side effects overall based on the studies I've seen. If that isn't working, the next step is typically a corticosteroid injection, and that can really help decrease inflammation. You can do those in joints once every 3 months. Do it too often, there can be side effects like fat atrophy of the skin, and you don't want to have that. So that's how we manage it initially. We also do physical therapy and occupational therapy, and that can help decrease the symptoms as well. It's not going to cure the underlying arthritis. People ask me about stem cells or viscosupplementation. There have been some studies that show the benefit, but nothing really has been shown to dramatically reverse the course of arthritis in that capacity. And the ultimate thing we do is end up replacing the joint. And that's one of the most successful procedures we have, joint replacement, especially in the hip. I do it often in the hand for the basal joint of the thumb, and patients are generally very happy with the outcomes from that. But that's the progression. We generally try everything non-operative first, and then if the patient has debilitating pain that keeps them up at night and they can't really function with, that's when we discuss joint replacement. And that's time. All right, last topic, carpal tunnel syndrome. So what is carpal tunnel syndrome? Basically, it's a pinched nerve in the wrist or palm area that creates numbness and tingling in the hand and pain up the arm. It's most often caused by overuse. You get inflammation around the tendons, and there's a nerve in there called the median nerve that's also inside the carpal tunnel, which is basically just a little tube that has all these tendons in the nerve, and it gets too much pressure buildup to the point where it pushes on the nerve and the nerve falls asleep and causes pain. So often I see it with people who do a lot of smartphone use, a lot of typing, but it can happen with other things like manual labor jobs, such as a carpenter or a mechanic. But it can be quite a nuisance and limits you at work. So what do we do to limit this? The first thing we try to do is activity modification. Figure out what's causing it. Sometimes people have a mouse that they're using on the computer all day with their hand like this. We get them a vertical mouse and the symptoms dissipate. So activity modification, splinting at night can be helpful to reduce the symptoms. Sometimes these symptoms wake you up in the middle of the night because your hand is basically numb and it's painful, and you have to shake it out to get the sensation back. And that is another option. Anti-inflammatories can work. Non-steroidal anti-inflammatory drugs can help decrease the swelling. You can also use topicals in the area of the carpal tunnel, and that may help. If that fails, corticosteroid injections into the carpal tunnel, especially if it's early, can really dissipate the symptoms significantly. But if despite all that, there's 3 to 6 months of continued discomfort and pain despite all conservative measures, we do order what's called a nerve conduction study and figure out if it's to the point where surgery might be required. Surgery is what is known as a carpal tunnel release, where we basically just make a tiny incision in the palm over the area of the carpal tunnel with local anesthesia and some sedation, and release the pressure in there. And that usually will decrease all the numbness and tingling, and patients generally do very well with that. And that's done. All right, that concludes this episode. If you enjoyed it, stay tuned for more. We have this coming out pretty much every week.